So hello everyone, this is Dr. Menist again. Let's talk about the tuberculosis. So in India, first time the program against the tuberculosis was launched in 1962. That was NTP, National Tuberculosis Program. But it failed to reduce the TB burden. So in 1993, WHO announced it as a global emergency, and in that year only, RNTCP pilot program was launched in India. Okay, after that in 1997, the full-fledged program was started in RNTCP. It was based on DOTS, okay, directly observed treatment short course, okay. And after the many changes had come, like in 2010, CBNAT was introduced. 2016, the beta-glucan tablet had introduced, and even the daily regimen. Before it was alternate days, okay. And 2018, they made it compulsory to notify the diagnosed case of tuberculosis. And in 2019, the RNTCP was changed to NTP, guys. That is National Tuberculosis Elimination Program. So they targeted 2025 as a target to end the tuberculosis in India. Okay, so what all updates had come in NTP, we'll discuss about that. So one is about the categories, right? Before it was category 1, category 2, default or not. So they have removed all the categories. Only now it is either drug sensitive tuberculosis or drug resistant tuberculosis. Drug sensitive tuberculosis, which they'll do by CBNAT, okay. So they'll so only that category is there, okay. Other than that, ethambutol, guys, before it was only for category continuation phase. Only for category 2 it was there, in continuation phase I'm talking about. But now ethambutol is compulsory for continuation phase, okay. In intensive phase, there are 4 drugs: HRZE, isoniazid, rifampicin, pyrazinamide, ethambutol. And continuation phase, 3 drugs, HRE. So there will be 2 tablets, okay. One is like color coded, green color and red color, okay. Green color is for the continuation phase, red color for the intensive phase. So this is changed. Other than this, daily regimen, as I said before, 2016 it was alternate day tablets here, but now the patient has to take tablets daily. So other than that, weight bands have come now. That makes it very easy. Okay, so fixed dose tablets are coming now. So you'll get isoniazid of 75 mg, rifampicin 150 mg, pyrazinamide 400 mg, and ethambutol 275 mg. So that all this content will be in single tablet. Okay, so based on the weight category, there will be bands of weights like 25 to 40 kgs, 40 to 55 kgs. So if 25 to 40 kgs, 2 tablets, like that. So 2-3 tablets. So daily that much tablets he has to consume based on his weight band. Okay, this makes it easier. Okay, other than that, guys, before what they used to do is, after 2 months of intensive phase, they used to repeat the sputum test, and they used to see if the patient CBNAT is negative or positive. If the patient CBNAT is positive, then they used to continue or extend the intensive phase for 1 month. Now it is not like that. Okay, now you have to monthly follow up the patient and see if the symptoms are subsided or not. Okay, so if the symptoms are not subsided and you suspect that the ATT is not working, okay, then you have to suspect for the drug resistant tuberculosis. For that, you have to send the patient for DST, that is drug sensitivity testing, okay, either by CBNAT or by the line probasis molecular tests. Okay, so based on that, you will take your decision. If the patient is positive but there is no resistance, you don't have to extend the intensive phase now. Okay, other than that, the big change has come in the follow-up, guys. Follow-up, earlier it was just laboratory follow-up. After 6 months of therapy, the patient will repeat the sputum CBNAT, and if it's negative, then okay. Okay, but now it's not like that. We have to clinically also follow, clinically with laboratory. Okay, every month you have to follow up. You have to see for the symptoms, weight gain is there or not, cough, night sweats, everything we have to say has improved or not. And other than that, even after the 6 months of therapy, you call the patients at 12 months, 18 months, and 24 months. That is 2 years. So complete 2 years of follow-up is there. We have to see for the clinical symptoms and even any adverse effects of the ATT, okay, LFTs and all. It is because most of them are hepatotoxic. Other than that, you have to see for any comorbidities they have in control or not. Okay, if the patient is diabetic, the sugar levels are controlled or not. If the patient is HIV, if he's taking the ART properly or not. If the CD4 counts. Okay, all these things you have to follow. Thank you.